Because what happens is the more immobile you get, the more antisocial you get.
Correct.
And we know the positive impact on social environments in elderly communities and how important that is. So if we start taking the movement away, we start taking the interactions away, the social contact away, and then you're on a bit of a slippery slope.
Welcome to Honestly Speaking with 360 Plus, your companion to holistic health. At 360 Plus, we take the best of nature and science and bring them together to address root causes that will help you heal from within and reclaim your life. And today we're with John Gloster, who is a leading physiotherapist. He's worked with the Indian cricket team. He is the medical coordinator for Rajasthan Royals. And we're talking about movement and its role in treating and managing osteoarthritis. The issue with osteoarthritis is, of course, aside from the aches and pains, it often leaves people feeling stuck because it's debilitating, right? You may not be able to complete ordinary tasks. Things like cooking, rolling a roti, these may become problematic, right? And movement, it's such an interesting subject because when you have pain, how do you move? And if you don't move, how do you get better, right?
You've touched on some of my favorite topics there. Obviously, in the intro, my love of sport has come out and I continue to be involved with sport at the elite level as well as right through the pyramid in India over the last 20 years. But as you pointed out, there are a lot of problems that we have in society in general that often start with a lot of our young athletes, and addressing them at a young age prevents a lot of these, particularly osteoarthritis.
Yeah, but you're saying that you're talking about when somebody gets an injury and then that
could
sort of
be
develops
a precursor.
into...
Exactly. So we need to look at the whole spectrum from children right through to when the conditions often present themselves later on in life. But getting the definition right also is really important. And I think there's a lot of confusion around the word osteoarthritis or arthritis. People come to me, very young people come to me and say, I've been told I've got osteoarthritis. And when we look at their images, I look at their x-rays, there's virtually no evidence of that in the real term,
I see.
of osteoarthritis.
So what's going on there?
So I think we're just using this blanket terminology for anybody who has a bit of aches and pains in a joint, which is a little frustrating because people associate that term, that definition, that specific disease nomination as being disabling, when in many cases it shouldn't be and often isn't. I think there's like 80 or 90 different types of arthritis.
Right.
And the two most common ones that you will hear and I will hear, we'll all hear about is osteoarthritis and probably rheumatoid arthritis.
Yeah.
They're two very, very different conditions. And then the other thing that I think we need to bring into the conversation here is the terms osteopenia and osteoporosis and how they sort of play a role in developing some of these other syndromes later on. As I said, having been here over 20 years, I still think we're trying to find a happy place in terms of treating osteoarthritic patients. And one of the reasons why we struggle with that or struggle with different interventions is because we're still not clear on the diagnosis and the case itself.
Why would that be? Why would there be confusion about the diagnosis?
Education and people being not educated on the differences in the types of arthritis that we said.
So you're talking about self-diagnosis then?
Yeah. A lot of people in India tend to self-diagnose or put it all into one bucket. When you put it all into an arthritis bucket, that bucket becomes very, very big.
Yeah.
And then we attempt to throw treatments at everything and hope that one of them sticks.
Right.
But if you make a more correct, a more pronounced diagnosis early on, then your direction of treatment becomes more focused and therefore your outcomes are going to be far better.
Right. So just right off the bat, if I can ask you, because you mentioned age and you mentioned children, and when we think of osteoarthritis, we think of older adults. Yes, of course, in few cases where injury has been sustained and then that develops into OA. But typically, you don't think about this being something that children need concern themselves with, right?
Not particularly, no. But in the cases of juvenile onset rheumatoid conditions where it can be, and that's a completely different bucket in itself. So most people, particularly in the older ages, are most affected by osteoarthritis in the weight-bearing joints, and so that would be knees, hips particularly. And you touched on it before, is you then tend to get into a cycle of, is exercise good?
Yeah.
And if I have pain, how do I attempt exercise? What is the process around getting back to activity?
Yeah.
And I think that's where most people come unstuck, is getting advice on when to intervene and what's the appropriate mechanisms of intervention.
Mm-hmm. So why is exercise such a crucial part of osteoarthritis management?
Let's go back first and look at the building blocks of joint health, bone health. And we know weight-bearing exercise is a really big part of that, because that's how bone grows, that's how bone develops, that's how bone turns over and renews bone, is through weight-bearing activity. And then the people that are exposed or overexposed to exercise, perhaps at a younger age, may get the benefit from the development of long bones, but they may then have the effect of overusing joints, which then later on in life may be impacted. So maintaining joint health from a younger age is critical.
Wow.
Because that will impact on the status of your joints as you get older. And particularly so in our athlete population, who have traumatized their weight-bearing joints, hips, knees, ankles, lumbar spine, through repeated high-intensity efforts. We can mitigate that to some extent, with particularly now, or more so in the last 10, 15, 20 years, because of our understanding of how to protect joints better. And that's where the exercise piece later on in life comes in, is that all joints rely on the muscles around them as forms of protection, what we call external protection. And they provide shock absorption. So the natural shock absorbers, if they're strong, the muscles, if you lose that, then your ability to absorb forces, running, jumping, hopping, walking, is reduced, and therefore the joint is more vulnerable to load. And then if you come back even one step more, then if we're looking at overall joint health and how do we further protect, is we've got to look systemically. So then we've got to look at nutrition, because that's the big player in all of this. And nutrition becomes a very, very important part of this. External supports that some people use in terms of bracing, strapping, taping, things like that may be effective. But I think ultimately it's about the patient understanding that arthritis is something that shouldn't stop them. But as I said before, it's about getting early diagnosis, and it's about getting early targeted interventions.
Sure.
But as we become more or have a greater understanding of the impact that arthritis has in later life, we therefore must become more mindful of what we're doing when we're younger, because that is another area that we certainly can control, particularly with our kids. So the big focus for me over the last 15 years or so, has been this taking our knowledge and advanced knowledge that we have in the elite sporting space and using some of that knowledge to come back and help with our younger kids, help with the way that we're protecting them later on in life. And that comes down to good nutritional practices, encouraging movement, encouraging weight-bearing activity. Or 90% of bones, particularly in females, is laid down in the first sort of 18 or 19 years of life.
Okay.
So we need to ensure that what is laid down is of great quality. And then once it's there, how do we then protect it for the rest of your life?
So what's interesting, so you've talked about women, which is obviously the large group that's predisposed to, or is more,
we tend to see more females predisposed or impacted later in life.
And when you talked about children, there is a genetic component to OA as well, right?
Yes and no. If a parent or grandparent direct line has there is evidence to suggest that you may have a greater risk later on in life.
Right.
But knowing that, or you've seen a parent struggle with that, then that does help us make decisions about how we challenge our kids when they're younger. How do we protect them. We don't protect, and I use this term a lot with sports people, so we don't protect you by wrapping you in cotton wool and, pampering you. We protect you by exposing you to the rigors and vigors of life. Particularly since my period in India over the last 20 years, one of the things I have noticed, and we've seen this is not just particularly to India either, is that the use of certain medications, things like what we call PPIs, which are proton pump inhibitors, antacid family, things like SSRIs, so serotonin reuptake inhibitors for anxiety and depressive disorders. A lot of the diabetic drugs that are being used, opioids, and the increased use of these in certain populations and the negative impact, therefore, on bone health is quite significant.
Really?
So we really need to be careful that when we're prescribing medications, particularly to younger children or younger adolescents or younger adults, that we need to then find ways to offset that potential damage to bone health.
Well, that's so interesting because nobody talks about that though when they prescribe it.
And there are a lot of medications that impact on bone health. So even some of the thyroid medications. So they're the things we need to be mindful of as we move forward in life, that if we are prescribing certain medications to our younger populations, then we need to find ways to therefore offset the negatives to that with some more positives. As I said, exercise, nutrition, weight bearing.
Wasn't that also true for later on in life?
Yeah, very much. And this cohort, sort of between that 60 and sort of 70, 80 cohort, where typically they'll get a bit of knee pain, they'll go to the ortho, he'll do an X-ray and say, you got some degenerative changes. Look, I think it's best we do a TKR, a total knee replacement, or a unicompartmental knee replacement. And I've seen many, many cases. There's a dear friend of ours, she was given that advice 9 years ago.
Could you tell me the age group?
70.
Right, okay.
She was given that advice 9 years ago to have a TKR. She had image findings that would suggest she required it. But you should never diagnose and treat only on an image finding. Her X-ray wasn't great to look at.
Okay.
But when you talk to her about her activities of daily life and her current, what we call standard of living physically, she was in a really good place. She was still walking an hour every day. She wasn't getting swelling. She wasn't waking up in the night with joint pain or discomfort. She had no morning stiffness. She was able to get up and down out of chairs and be completely functional. So she was able to do everything that she wanted to do.
So you don't necessarily...
But her X-ray said otherwise. So that's not how we treat anymore. We don't just treat on images. When you put the two together, it's a very different picture.
Yeah.
So she's gone 9 years without having a total knee replacement. Once we made the diagnosis, we then embraced the concept of, okay, we'll tackle this in a different way, what we call conservatively.
Which would involve...
And see how you go. And what that involved was nutritional changes, weight. We know that, for every extra kilo that you carry, it's an extra 3 kilos borne through the knee when you're walking. It's an extra 6 kilos when you're going up and down stairs. And it's an extra 4 or 5 kilos when you're light jogging. Things like getting stronger, rebuilding your natural shock absorbers.
When you talk about rebuilding, you're talking about, again, what, weight? Is that what we're talking about?
Yeah, so resistance training.
Yeah.
And all of us, particularly us, over 50, not that you're over 50, but...
just crossed that milestone.
But particularly in that cohort, resistance training needs to come to the fore because of a host of other benefits, insulin sensitivity, and there's a whole load of other benefits. But one of them is protection, and you need to protect yourself against a condition that is progressive if you don't look after it, but doesn't have to be progressive. Now, resistance training doesn't necessarily mean going into the gym and start lifting heavy weights. That's not what I mean, because at the same time, you've also got to understand that joint is not yet able to be protected against heavy forces.
Right.
So how can we be smarter around creating environments that we're going to train those muscles without loading the joint? So that's where things like TheraBands and resistance bands, aquatherapy and hydrotherapy has become a really big one, because everything you do in water is against resistance. So it's resistance training, but you're not getting the joint impact.
So even when people are walking across...
Yeah, it's fantastic. Yeah. So being smart around that, and then gradually progressing those programs to more, as I said, more weight bearing, more functional and adding in movement patterns that are important and relevant to that individual. So there are so many options before you go down the surgical route. There's some fantastic injections that we're using now, Ostenol, Synvis. They're basically all forms of hyaluronic acid, which helps to preserve and cushion the interior of the joint. So there are a lot of things that we should be attempting before we necessarily go down the surgical route, and I don't think we explore those enough.
So I want to, before we get to again, I do want to know if somebody's diagnosed with OA, if this is something they've discovered.
And normally that's done on, say, imaging. So X-ray is normally the main one that they'll diagnose on.
So what would be the first exercises that you would recommend they start doing? And also even before that, right? If I know that as a woman, I'm already predisposed, as you said. So how then, is there something I should be doing for my joints, something simple that I can do?
That all depends on the joint, which joint it is, but it's usually knee or hip in most cases. And then it's about your previous level of function versus your current level of function. So it depends how much that condition, arthritis, is impacting your current ability to function in activities of daily life or things that you want to do. So that then determines the sort of the input and where you start your exercise routine. But remember that at the foundation of it all is exercise.
Right.
The other way to look at this also, particularly, and in most people who have osteoarthritis will have some element of either osteopenia or, which is the precursor to osteoporosis. We've got to try and mitigate risk, because the risk of somebody who has osteoporosis is fracture.
Okay.
And therefore, how do we protect them? It's very difficult to then change the osteoporotic or osteopenic nature in terms of rebuilding bone at that age. It's quite difficult. So what are the mechanisms, therefore, to protect that bone from breaking in the first place? So that's where things like balance training and reaction training and ultimately strength and things like coordination, because most people, as they get a bit older, become a little bit less balanced, a little bit less stable, and they trip and stumble, then fall and expose that bone to the forces that are going to cause it to fracture because of its porous nature. So how do we wind back and look at how do we reduce risk of falling in the first place?
Sure.
And part of that is what you're saying is exercise, balance training, reaction training. It's critical. We often don't address that.
When you talk about balance training, what is that?
Standing on one leg for starters. Can you stand on one leg for,
really? Something as simple as that.
Your eyes closed. So easy, as simple as that. Getting people out of shoes and walking in bare feet on different surfaces is huge, because what we do when we put a pair of shoes on is we dampen all our natural feedback mechanisms to the brain.
Sure.
It's what we call proprioception.
Yeah.
About where that limb is in space. We've got to get smarter at the way we train elderly people. We've got to go back and train them almost like we train kids, young kids. And exposing young kids to barefoot walking on different surfaces is critical for their development, their neurological development, and their reactions and their balance training. So we almost wind back and take cues from what we did with our kids, or as we did with kids, and bring that into the environments of our elder population who are at risk. And we don't look at it enough. We just think, when I say get stronger, immediately people think I've got to go to a gym. And that can be a barrier in itself.
Yeah.
And people, oh no, I don't want to go to a gym. They have a vision of a gym of, big guys pushing heavy weights and, running up and down.
Yeah.
And it's quite a threatening environment for a lot of people. So how do we bring the gymnasium into the house first?
Right.
At least start there, or into their everyday life. Prior to that is the education around what we're doing and why we're doing it.
Right.
Because we can impact positively on your current condition. Because at the root of most problems, particularly things like arthritis, rheumatoid arthritis, in particular osteopenia, osteoporosis, is inflammation.
Yeah.
So if you're then fueling your day with inflammatory foods and cooking in inflammatory mediums, then that's just going to exaggerate the problem, exaggerate the acceleration, or accelerate the degenerative processes. So starting with nutrition, I think, is a really, really important one.
So when you talk about inflammatory medium for cooking, what is that?
Yeah.
And also nutritional. I know when we talk about nutritional problems, is it the Indian diet that you're
not just the Indian diet? It's pretty well every diet now. But look at what we're cooking in. As I said, the mediums that we cook in, the majority of mediums, the oils that we cook in, are hugely inflammatory. Your seed oils, what we call your seed oils.
Mm-hmm.
So you call them vegetable oils, but they're actually seed oils. And the amount of processing that they go through to become edible to the human being makes them very, very unstable and extremely inflammatory.
Like your sunflower seed oil?
Sunflower, safflower, canola, rice bran, horrendously inflammatory.
Really?
Yeah. Just now that I've brought it up, you'll start seeing just how impactful they can be, particularly on inflammatory conditions. So omega-3s are your big inflammatory dampeners. They're the good guys. So what are the oils that are the high in omega-3s? What you would term your traditional cooking methods. So you go back and ask your grandparents what they cooked in. Mm-hmm. It won't be all of these modern oils. It'll be traditional ghee, coconut oil.
So ghee is good.
A little bit of ground nut, perhaps, small amounts. Extra virgin olive oil for the Caucasians, Mediterraneans. Even some of the newer ones now that are coming through, things like avocado oil, things like that, because they're very, very stable and they're very anti-inflammatory in nature. We know inflammation sits at the source of all disease,
right?
Particularly in my space, in injury and poor recovery and things like that. And then the other big babies that often impact on the inflammatory cycle is your processed foods, your processed carbohydrates, particularly in sugars. Hugely inflammatory. The other driver is cortisol. Cortisol, which is your stress hormone, and that can be either physical or emotional stress, is also inflammatory. You can't just point at one thing and say, do a bit of exercise, it's going to fix your osteoarthritic knee. That's a very important part of it, trust me. But let's start looking at the complete picture for the complete person. There are certain drugs that impact on joint health as well, like statin drugs, your anti-cholesterol drugs, which a lot of people are on these days.
Yes, of course, yeah.
And the way they impact on a certain chemical chain that has CoQ10 on it, has vitamin D3 on it, has testosterone on it, has a number of other hormones building capabilities on it. And when we take a statin drug, it reduces all those in the system. So joint aches and muscle aches is a big side effect of being on statin drugs, and also muscle weakness. So you get significant muscle weakening on the back of taking a statin medication. So again, how do we look at the complete picture of that individual?
So I find it really interesting because I'm not on statins, but I do know people who have been and who are on statins. Of course, it's not something that comes up in casual conversation, but I don't think that they would have been informed that this would be part of...
So, for example, anybody who's taking a statin drug would probably be best advised on also taking a coenzyme Q10 at the same time.
Right.
Because we know that...
But without explaining why.
Because the CoQ10 is it's what they call the spark of life. It's one of the energy systems for cardiac muscle, for starters. So CoQ10, D3. So all these things need to be part of your treatment package, so to speak, for that individual if you want to get really, really good results. And collagen, which is your joints, the lining of all your joints are made of collagen, your tendons are made of collagen, your blood vessels are made of collagen. Now collagen, the building block for collagen is vitamin C. And humans are the only animals on the planet that we don't make vitamin C ourselves. We need it exogenously. So are we taking enough vitamin C to support the growth and repair of degenerative tissue and keeping our tendons and ligaments and joints in really good health? And understanding also that, which a lot of people don't understand, is that vitamin C and glucose compete for the same receptor site on the cell, and glucose gets priority. So if you're taking vitamin C with something really sweet with glucose in it, most of your vitamin C is not going to be absorbed.
Oh, that's interesting.
So therefore the impact on the joint, so we've got, again, you need to start looking at the big picture of health.
But that's why we have this podcast. The whole idea of this whole season is aimed at osteoarthritis. Exercises. I know you said it really depends on what stage of OA you're at and what will work for you.
Because sometimes exercise at that point in time for that individual may be too much. So you've got to go back and and progress through. If I said you've got to exercise more to someone,
right,
and without explaining what I meant by that,
right,
relative to their condition, they'll say, "Okay, great." So they'll go out and go for an hour walk,
right,
and then that may be detrimental to their primary problem.
I was just going to ask: is high impact exercise?
So again, education, first, education to that individual is the number one piece.
So you understand what works for you and what doesn't.
Why are we doing it?
Right.
What is the problem first?
Yeah.
And how we can impact on that. So why are we doing it? So the why is so important.
Are there some exercises that are just better for you if you have OA, like swimming and yoga? And are there some exercises which would be off limits? High impact exercises.
There's a bit of
jogging,
sort of chicken and egg here. What should come first, so to speak. Firstly, diagnosing the individual completely is really important because, as I said before, often they'll have perhaps a degenerative osteoarthritic knee. More than likely, they're going to have some sort of osteoporotic condition as well, or osteopenic condition.
Okay.
Both require slightly different things.
Okay.
So for osteopenia and osteoporosis, you want to encourage weight-bearing exercise. But that may be detrimental for their knee arthritic degenerative condition.
So how do you
So we've got to find a way. At what point do we then get this supported first?
Yeah.
Protect that with offloaded resistance training. Then when it's supported enough, it's strong enough, then you can start introducing the weight bearing because you do need both.
How do you do it when you are already in your late 60s or 70s and you spent a lifetime that's been pretty sedentary, so your muscles aren't strong?
Yeah, which is probably why they're in the condition they're in currently.
So how do you go? I mean, how do you
Well, again, you can lead a horse to water, but you can't make it drink, the old saying.
Yeah.
So you've got to outline to them, what do you want to get out of this?
Right.
What do you want to get out of the next 30 years of your life? How do you want that to look? Because you've got to get their buy-in.
Right.
But also highlighting to them the benefits that by a small amount of intervention, the impact is actually quite big, positively. Because what happens is the more immobile you get, the more antisocial you get.
Correct.
And we know the positive impact on social environments in elderly communities and how important that is. So if we start taking the movement away, we start taking the interactions away, the social contact away, and then you're on a bit of a slippery slope.
Correct.
So you've got to try and bring that into the conversation. The more mobile you are, the more interactive you are, not just physically, but emotionally and socially. And that is one of the biggest drivers because then that impacts on cortisol.
Yeah.
We know being in positive social environments with communities brings cortisol levels down, that brings inflammation down, that brings, so again, how do we look at this complete picture? Yeah. But movement sits at the core of most things. And I've always said that.
Right.
And walking more specifically and the value and benefits of that. And particularly in our sort of 50 plus population, and how do we encourage that? And it's very difficult to tell someone just go and walk because it's good for you.
Yeah.
That's not enough. What is the good?
Yeah.
The good is not just physical, it's mental, emotional, social.
To ask somebody who's in pain to do something, to move, when that movement itself is so painful.
Yeah.
How do you do that? How do you strike that balance? Yeah.
So breaking the pain cycle is important because pain is also a muscle inhibitor to some extent. So we may need to intervene at some level and break a pain cycle.
So what does that mean? Resting?
So that could be resting in some cases. It could be bracing, strapping, external supports, like I said before. It could be something medicinal. So it could be an intervention, and that could be Ayurvedic, could be naturopathic, could be allopathic, could be something. But at some point, if we really want to get the desired result, we're going to have to break that pain cycle somehow.
Right.
Okay? Because that's obviously the factor that's stopping them moving in the first place. So once we've done that, we've broken the pain cycle, they need a better position to strengthen the muscle, which then allows the joint to be supported, which then allows further activity to be advanced. You may need to manipulate the environment slightly, which means you might, going into a pool, it might mean things like cycling, stationary cycling, because you don't want to get the joint loading, but you want some sort of joint movement, but without the impact. And by doing so, you're then stimulating the muscle activity around the joint.
So I've actually met somebody years ago when I was an aerobics instructor, ages ago.
How are your knees?
Sorry?
How are your knees now?
Perfectly fine.
There you go. You stayed strong.
So I met someone, and it was really surprising to me. She was about the same age as I back then. We were in our 20s, and she had never exercised at all.
Yeah.
Right? So any kind of exercise you introduce was not only met with resistance, but it was hard to do.
Yeah.
So simple things like we had to. So it was really, really difficult for me because I'd never met anybody like that before. To just begin with just taking a few steps at home and just start. Are there any simple activities that you would prescribe to someone who maybe has started struggling with OA, but isn't familiar with exercising or the whole concept of exercise? And it sounds ridiculous, but a lot of people aren't.
So true. But the introduction of the exercise is and for many, it may just be starting to walk around the house. For many, they don't even do that. If they want something from the kitchen, they'll just call for it. But actually, when you add those steps up over a day, suddenly instead of it being 500, it's suddenly 1,000.
Do you feel it's a good idea to maybe when you're on the phone, maybe just
to keep
walk
moving?
around,
That's why they're called mobile phones, aren't they? I mean, that's what the idea of them was, to be mobile while to provide mobility in your conversation. So something as simple as that. Now, it's all about building out what we call exercise endurance and work tolerance. Because again, if someone who's never leaves the house and does 500 steps a day, if I tell them, it's really good for you to go out and do 30-minute, you've got to get your 10,000 steps a day, it's just ludicrous to expect them to, first of all, appreciate that and then even attempt it. And if they did attempt it, they'd be worse off anyway. Then once you've had a negative experience to exercise, you then tend to not go back to it. So how do we make it fun?
Yeah.
And that they're going to see benefits straight away, well, as quickly as possible. So I think that's the area that we need to get a little bit sharper at is this early exercise prescription and tailoring it to individuals and their history. As you said, your friend never had an exercise history. So it's what we call a very immature training history. To expect them to be mature not only in their mindset around training, but in actual training would be ridiculous.
Do you have any strategies to deal with the pain before exercise, after exercise, to sort of mitigate?
So if you understand that in a lot of these conditions are inflammatory, so therefore often ice is a treatment modality that will help afterwards.
Cold compress.
Because when you're first starting to do some of these activities, you may set up a little bit of an irritation, which you then want to dampen down. That some people, when it comes to muscle, prefer heat. So the joint is separate to the muscle. So some people apply heat before to get the muscle moving.
Is that an optional thing, or is there just like this is better to do?
It's up to the individual.
Really?
But if I was to advise somebody, I would start with heat for the muscle and ice for the joint.
Okay.
Because basically what you're trying to do is relax the muscle. That's what heat does. Increases circulation, improves recovery, relaxes the muscle. Whereas if you're just targeting where the inflammation is, that's most likely just in the joint. And so ice, therefore, is going to be more effective for tackling that.
Interesting. Okay. I didn't know.
So you can look at it from that perspective. Ideally, you don't want to go down the medication route. You want to do it without medication. So things like, as I said before, there are certain supplements that you can take that can be really beneficial.
Like, I was told rosehip as well.
Yeah. And there's, as I said, there are a lot of sort of naturopathic, Ayurvedic approaches that are really good. I always say, don't underestimate the power of hands-on, like soft tissue massage, release massage. Some of these Ayurvedic oil interventions can be really beneficial, and a lot of some of the physiotherapy practices where joint mobilization, mobility activities around the joint with hands-on is can be really beneficial.
Right.
Some people find some sort of cushioning braces can be really effective in their early journey back to activity that absorbs some of the forces until their muscles get stronger.
Yeah.
But
so you
don't
have a knee brace, but what would you do if the hip was the problem?
Yeah, so that's where you got to rely on your muscles. The good thing about hips is they respond really well to muscle training.
Okay.
And people say, oh, how do you train hip muscles? Well, one of the major ones that supports the hip is your glute. Your glute muscles, your gluteus medius, maximus. So doing some basic hip training, even just bridging, exercises really engages your glutes.
Yeah.
But then look at the entire chain, because I mentioned before about it being shock absorption. So if you can imagine forces coming up when you strike the ground, you've got several shock absorbers on the way before it gets to the hip or the low back, one of them being footwear. So being in the appropriate footwear that helps with that first. Calf conditioning. People forget about the old calf, but per unit volume, it's the strongest muscle in the body.
So which is just getting on your toes and...
Just getting up on your toes and getting that switched on. Because your calf passes over the back of the knee and therefore provides a lot of support, shock absorption and cushioning for the knee joint, but also protects the hip. Because ultimately it's absorbing forces coming up. And then your hamstring and quadriceps before you get to your glute muscles. So part of your hip strengthening protection plan, as I call them, will involve all the other key muscle groups that sit below it. So always think, ground up.
Would Pilates be something that you feel people should?
I'm a big fan of Pilates because I mentioned before about a big component of protection for people with these conditions is balance. Balance, coordination, stability, all those terms. And if there's one training medium that gives you that, protects you, gives you mobility, gives you flexibility, which is important because often these joints stiffen up a bit, and Pilates is probably the one. So Pilates is probably one of the training modalities that gives you that all-around protection for that condition. So I'm a big proponent of Pilates. Yoga is another one.
So what should my week look like?
So again, with yoga, there needs to be you can't just suddenly start yoga on a really stiff arthritic joint.
Right.
You may irritate it. Again, there's a process to that, as there is with Pilates, as there is with walking, as with any intervention. But I think there's so many really good options available to us, particularly in this region, because yoga is widely practiced and widely accepted. Pilates has become much more widely accepted and much more widely practiced by really good practitioners.
Yeah.
And good soft tissue therapists, good physiotherapists, good interventional therapists. So we do have expertise now that we didn't really have 10 or 15 years ago. But ultimately, it comes down to what that individual is able to do or not do.
Yeah, what sort of level of mobility they have.
And that's the level you start at. Yeah. And then an understanding of where do they want to get to.
Sure.
So that helps you plan their journey, their exercise journey, and ultimately where they want to get to is all that matters.
And your approach would include nutrition, obviously, you spoke about, exercise, of course.
Yep.
And supplements as well.
Yep.
Right? So it's a holistic approach.
Yeah.
That sort of
very holistic
best.
approach. And then I said, don't forget the things like, the community, social, interactive. That's why sometimes doing joint classes or group classes are really important.
Right.
One, it gets you engaged. Two, you're more likely to do it if you're with some friends. And then you're bringing in the community, social environment piece as well. Think big picture.
Yeah.
There's one thing you want to take away from this is that I don't think we think big picture enough. I think we just become, oh, he's got arthritic knee, you got to do some exercise and that's it.
Mm-hmm.
But that's a very, very small part of it.
So quick myth-busting round. True or false? Pain during exercise always means damage.
Not always. So pain is a guide. But again, understanding that patient, their pain thresholds and their condition helps you set what their thresholds are in terms of what's acceptable pain and what's not acceptable pain.
So if I'm at the gym and I have a little soreness the next day, that's fine.
That's fine.
That's
so
fine.
we look at pain across 3 phases: during the activity,
Mm-hmm.
immediately after the activity, and then 24 hours later. 12 hours and then 24 hours. So if it's there during the activity, but after you finish the activity, it's gone away, we'll just make a note of it. If it persists after the activity and then it's still present either as pain or stiffness the next morning, we need to back off a little bit.
High impact exercises and weights are off limits for anyone with osteoarthritis. True or false?
Again, we're going to break that down into 2 things. Weights can be very beneficial,
right,
as we just discussed.
Yes.
But it's how you progress those weights and what joints you're targeting and what stage of their osteoarthritic journey that they're going through.
And strengthening
the
muscles.
That will determine the appropriateness. But weights, when I talk about weights, it means resistance training, which we know can be very beneficial.
Mm-hmm.
High impact training, and you've lived that journey yourself with your aerobics, et cetera, but high impact training, you got to look at what's the risk versus the reward.
Mm-hmm.
So the potential risk of irritating that joint is probably higher than the reward you're going to get out of that level of training. So high impact, we would take out of the equation to start with.
Okay. And
then see how they go through their various phases of return to impact to see if they tolerate it or not. But in general, high impact training on an advanced osteoarthritic joint would not be advisable.
Right.
But then build the protection around it,
mm-hmm.
and see how much they can tolerate and work within their tolerances.
Sure. Rest is better than movement during a flare-up.
That will only be in response to activity.
Yeah.
So flare-up will be because you've overdone it, you've walked too much.
So say you've done that.
So then you may need to back off a little bit, 100%.
Mm.
So pain becomes your guide, inflammation or swelling becomes your guide, night pain becomes your guide, and morning stiffness is your guide.
Night pain is your guide.
Yeah. So if you've got pain, you wake with pain at night in the joint, that means you've really overdone it. So therefore you do have to rest off until pain comes back down, and then you can start your journey again.
Okay. This is something you talked about again, just to bring it back. Heat therapy is more effective than cold therapy for osteoarthritis.
Yeah. Some people find that when they go to cold environments, they get really sore and achy, which is real.
Mm-hmm.
The other is atmospheric pressure, because that impacts the pressure inside the joint.
Mm-hmm.
The joint's already exposed. The nerve endings are already exposed because of the degeneration. So that can be real as well.
Mm-hmm.
So it's really up to the individual. But if it's inflammatory in nature, then obviously ice at some level is going to be beneficial. People often find that their joint is soothed when it's actually warm. But muscle will be something that will benefit more probably from the heat, because that'll allow the muscle to relax, which then takes some of the pressure off. But also, a lot of people tend to find that even though ice can irritate environmentally when it's cold, they get more benefit the next morning if they ice rather than put heat on the joint. So, but that's a bit of trial and error for a lot of people. Okay. So my indicator is how are you the next morning as a result of doing one or the other. And whichever one helps me best the next morning is the one that I'll stick with.
Okay. And early diagnosis of osteoarthritis can significantly improve long-term
outcomes. That's true.
That's true.
Yeah, because then you can remove things that are going to exaggerate it.
Yeah.
So inflammation, excessive joint loading, poor protection, weak muscles, supplementation, all these things that we can then impact.
Right.
And most of the time, the main driver is load. So for a period of time, if we can remove the mechanical stresses through that joint, we can then slow down that rate of destructive change or degenerative change in the joint lining. and then input our positive things: muscle protection, bracing, taping, oral supplementation, good nutrition, anti-inflammatory, shock absorption, etc., etc.
Right.
Then you'll see people go for huge extended periods of time with zero effect, zero negative. So I think, as I said to you at the start, I don't think, first of all, we diagnose well enough.
Mm-hmm.
I don't think we then educate enough on the back of diagnosis.
Mm-hmm.
I think sometimes we tend to prescribe on images and not on the person.
On actions.
And they're probably the three key areas that we've got to get smarter at. And then also appreciating the whole person and not just the degenerative joint.
That's amazing. You just summed up the podcast, really, which is what I want you to do. Thank you. So movement heals, as we've seen today, and every step counts. For holistic solutions that help you manage osteoarthritis, follow Honestly Speaking with 360 Plus. We are here to guide you with expert insights, science-backed remedies, and practical tools that empower you to reclaim your life. Share this episode with someone who needs that first nudge towards better health, and let's move forward together, stronger, one step at a time.